And she's Professor Shira Zelber Sagi, who is a full professor and the head of the School of Public Health, the Faculty of Social Welfare and Health Sciences from the University of Haifa in Israel. And we are very honored to have you here, Shira, to talk to us about lessons from recent dietary intervention trials.
Thank you so much, Hanali, and thank you so much for the invitation. It's my first time here, and I'm really excited for the opportunity to give my insights, which in a way I can agree a bit with Roy, but I also have some other thoughts, Roy, so we may argue about it a little bit afterwards. What I'm going to talk about, I have so many topics to cover in my talk, and I will do my best. But if you want the summary, the introduction slide, as well as the summary or the take-home message slide, then you have it right in front of you. Which are the foods recommended? Obviously, Mediterranean diet. Obviously, we want physical activity. What are the foods which are unrecommended, and what are the neutral group of foods which have no evidence for either harm or beneficial effect? And of course, I agree with Dr. Taylor, with Professor Taylor, that weight reduction is essential. If we have an obese patient, we need 5 to 10% weight reduction. If we have a so-called normal weight patient, as we heard, because I wanted to ask if there is anything like that anyway, a normal weight patient, because even if the BMI is normal, then they have excess fat tissue and excess abdominal obesity usually. So we also want weight reduction, even minimal weight reduction for the normal weight patients, especially if they have abdominal obesity. So I will try to cover all these topics, so stay with me. So first of all, I would like to discuss clinical trials of structured lifestyle intervention. I will only present the most recent ones in NAFLD. Before that, few things about Mediterranean diet. You're all familiar with Mediterranean diet, but I want to emphasize 2 points. One point is that the Mediterranean diet is actually a reduced carb diet. Only 30 to 40% of the calories come from carbohydrates in Mediterranean diet. So as compared to usual diet with 60% of the calories coming from carbohydrates. And also I want to emphasize that this is a diet that contains very little ultra-processed food. This is mostly a diet based on home-based cooking. And this is a very important point for the rest of my talk. So let's start with Mediterranean diet. We have the study from Circulation from 2017, comparing Mediterranean diet to low-fat diet with and without physical activity for 18 months. And we can see that weight reduction was similar in all our arms, but the reduction in the amount of liver fat was greatest in the group receiving Mediterranean diet plus physical activity. So if we look at the reduction in liver fat without physical activity in yellow, it's the same between the two diets. So actually both diets are good for liver fat reduction, but once we add physical activity, we see a kind of an interaction actually, where the combination of Mediterranean diet and physical activity have the greatest benefit on liver fat reduction. Unfortunately, this study had no other measures of liver damage as liver biopsy or any liver markers. And then the same group conducted another 18 months randomized clinical trial. And this time they compared 2 types of Mediterranean diet. One was the usual one, and one was with further reduction of meat intake, which is very important, and increased intake of polyphenols, which are strong antioxidants. They added green tea and mankai plant and walnuts to increase the polyphenols intake. And surprisingly, although weight reduction was similar, we can see that the reduction in liver fat was actually twofold in the group receiving Mediterranean diet enriched with polyphenols. And this actually emphasized the importance not only of weight reduction, but also of dietary composition. And they try to see which are the best predictors for the reduction in the amount of liver fat. It was the reduction of meat, increased consumption of walnuts, which are rich in omega-3 fatty acids, and of course increased consumption of polyphenols. All that was adjusted, of course, to weight reduction. Interestingly, we have demonstrated in an observational study of almost 800 people, we carefully studied their dietary intake and we calculated the phenolic acid intake in their diet. We adjusted, of course, to other lifestyle risk factors and BMI, and we've shown that higher consumption of phenolic acids, which is a subgroup of polyphenols, is related with reduced chance of having fatty liver on ultrasound and reduced chance of having significant fibrosis according to fibrosis markers. If you want to know which foods you need to eat now, so you can see on the right side below the foods that are rich in polyphenols. Not surprisingly, coffee is also rich in polyphenols. And if we want to look at further randomized clinical trials and look at liver markers, we can see that short-term, relatively short-term RCTs of 6 weeks to 6 months duration have shown beneficial effects of Mediterranean diet for the reduction of liver stiffness, fatty liver index, and also insulin resistance. The largest long-term study that I've so far is this one, published recently. It's a small study, but with 2 years follow-up, and they compared low-fat diet and Mediterranean diet. And you can see that in 24 months, the weight reduction in the Mediterranean diet was greater, and also there was a greater reduction in liver fat and liver stiffness. But once they adjusted to the weight reduction, there was no difference between the diets. So you can say it's all about the weight reduction that was greater with the Mediterranean diet on the one hand, but on the other hand, we might say that the compliance to the Mediterranean diet is easier for the patients. Let's talk about less conventional diets now. It is really, really a hot topic now, the issue of intermittent fasting. And so you can see there are several types of intermittent fasting. There is alternate day fasting. There is the 5-2 diet. In 2 days you don't eat much and the others you eat more. And there is the usual and most common time restricted eating, usually 8 hours per day, and then 16 hours of fasting. There is some evidence showing beneficial cardiometabolic benefits and weight reduction with these diets. However, the studies are usually short terms, 8 to 12 week studies. There is reduced calorie intake and reduced weight, so it's not independent of calorie restriction and weight reduction. The beneficial effect on cardiometabolic factors is actually conflicting, but generally we can say these diets are quite safe. And there are very few studies looking at these types of diet in NAFLD patients. One of them was looking at 5-2 diet. 2 days a week you eat 500 calories and the rest you eat almost freely, but generally healthy diet. It was compared to low carb, high fat diet, and weight reduction was the same, about 7 kilograms, and liver fat reduction was the same in both diets, meaning the intermittent fasting is the same as the usual diet, but still it's good news for patients who want to use it. And then there is a short-term study, 8 weeks intervention, alternate day calorie restriction compared to no intervention and leading to ALT reduction and liver stiffness reduction. Another study compared alternate day fasting and time-restricted fasting in NAFLD patients for just 12 weeks. So it's a short-term trial. And we can see they both led to similar weight reduction. However, disappointingly, there was no change in liver stiffness in both diets, but we need to remember it's a short-term trial. And again, disappointing results too. Randomized clinical trials, not specific for NAFLD patients, showing the time-restricted eating, alternate day fasting compared to usual caloric restriction leads to similar weight reduction in 12 months. And another study just published in New England Journal of Medicine, looking at time-restricted eating versus regular diet, both calorie restricted, both led to similar weight reduction and similar improvement in cardiometabolic risk factors. And let's move to low carb diet. This is also very common diet. So first of all, there are several types of low carb diets. As I said, Mediterranean diet is a reduced carb diet. Then we have the low carb diet with about 20% of the calories coming from carbohydrates. And then we have the keto diet that was just mentioned here. Generally, in this meta-analysis, although you can see not many studies were included, randomized clinical trials, there was no superior effect of low carb diet over usual low fat diet. And in fact, when we look on the time of follow-up, we see that although in the very short term, it seems that low carb diet is more beneficial, eventually when we keep following the patients for a couple of weeks, up to 24 weeks, we see that the diets are similarly effective. Now, we need to talk about the type of dietary fat. If we reduce carbohydrates, then obviously the caloric intake coming from protein and fat is increased. So what type should we recommend? What type of fat should we recommend to our patients? It is incorrect anymore to discuss the total amount of fat in the diet. We need to discuss the exact type of fat in the diet. And this is a beautiful review from Nature, Gastroenterology and Hepatology, emphasizing that in short-term randomized trials, a couple of weeks trials, saturated fat consistently increases liver fat more than polyunsaturated or monounsaturated fat. As you can see in the figure, this is a hyperenergetic diet. These are feeding studies, but it's also true for isoenergetic studies mostly. So this evidence actually supports the importance of Mediterranean diet or low-fat diet that are low in saturated fat and high in monounsaturated and unsaturated fat. So the type of fat is important. And so it's not surprising that the 2015 United States dietary guidelines actually lifted the ban on total dietary fat. We don't talk anymore about the total fat intake. We only emphasize to optimize the type of dietary fat and not necessarily reducing the total fat intake. Now, we've mentioned several types of diet, and this is my summary for the current evidence with the level of evidence. So the Mediterranean diet is actually the most evidence-based diet for the treatment of NAFLD. Low-fat diet is also beneficial, but actually they share common characteristics. If you look at it carefully, they're both low in sugar and low in saturated fat. Now, if a patient chooses to do low-carb diet, ketogenic diet, time-restricted eating, it's fine, but probably the principles of low sugar, low saturated fat, and low ultra-processed foods should be kept anyway. So let's talk a little bit about dietary composition. What are the things that we must discuss with our patients? First of all, this figure from the Cardia study emphasized very nicely that the prevalence of NAFLD is increased when the diet is unhealthy and reduced when the general dietary score is healthy. The more you eat fruits and vegetables, you have lower prevalence of NAFLD. And interestingly, the more you eat meat, you have higher NAFLD prevalence. And again, dietary patterns are summarized in this meta-analysis. Western dietary pattern is related with a 60% increased chance of having NAFLD, while prudent diet reduces the risk. And Mediterranean diet, not surprisingly, reduces the risk. These are, of course, observational studies. So let's talk about specific foods. Red meat is associated with increased risk of having NAFLD. Again, observational studies. Soft drinks, not surprisingly, increase the risk of having NAFLD according to this meta-analysis. And nuts, which are rich in omega-3 fatty acids, as I mentioned, and polyphenols, reduce the risk of having NAFLD. All these, by the way, are adjusted for body mass index. Two other interesting dietary patterns are related to insulin resistance. These are two scores. One reflects insulin resistance and one reflects hyperinsulinemia. So how do you build these scores? You can see that processed meat, for example, is in the bad guys side. It is related with insulin resistance. Potatoes too, but eggs too. This is a bit strange, but if you look at the Foods that are not related with this pattern, it's also surprising. For example, fruit juice, sweet desserts are not related with eating pattern that leads to insulin resistance. So these indexes are really a bit unusual in the way that it analyzes nutritional intake. But we can see in this very large study of the ENHANCE survey that the more you have hyperinsulinemic, greater insulin resistance related dietary pattern, you have a greater chance of having liver fat and fibrosis according to liver stiffness. And about meat, we had an interesting study. It actually showed that high red and processed meat intake is related with NAFLD, but the more interesting point was the way that you cook the meat. So we asked in our questionnaire we took a very detailed information about the type of meat and about the way they cook it. And if they fry it or prepare it to a level of very well done, then we calculated higher consumption of heterocyclic amines and higher consumption of advanced glycation end products, which were related with insulin resistance. So it's not only the meat and the type of meat, it's also the way that you cook it. Similar results we have also found in the multi-ethnic cohort in the United States. We've shown that red meat, processed meat, and even poultry, if consumed in a high amount, is related with NAFLD with and without cirrhosis, while high intake of fiber is protective and high intake of cholesterol is related with NAFLD with cirrhosis. Another study shows similar association. This is the Nurses Health Study, very, very nice prospective cohort study showing that red and processed meat intake are related with NAFLD. The association was partially mediated by heme iron intake, cholesterol intake, and very much mediated by body mass index. So we can't separate the effect of exactly the dietary composition and BMI. We need to acknowledge that, but there still seems to be some independent association. And more importantly, they have shown that if you switch 1 portion per day of meat with plant-based protein, then you get 5% relative reduction in the risk of having NAFLD. So 1 portion per day maybe can make a small difference if you change it by plant protein, calculated by combined nuts, grains, and legumes. Soft drinks, we must discuss soft drinks. This this prospective cohort study shows us that if you have 4 portions and above a week of soft drinks, sugared beverages, then you have 50% greater chance of having NAFLD diagnosed by ultrasound. And they also demonstrated some dose response association with the amount of soft drinks. This is a very nice randomized clinical trial. It is actually double blind. Here, the people were all receiving low fructose diet. Everyone got low fructose diet, but blindingly, they were getting fructose or glucose sachets for a couple of weeks. And we can see that those who received the fructose sachets did not reduce their liver fat content, while surprisingly, those who received the same amount of calories from glucose did reduce, or more significantly, to be accurate, reduce the amount of liver fat. So that, and the calorie intake was similar between groups. So it's a small study, but still very interesting, showing the differential effects of fructose and glucose. Another study to support that was published in JHEP, showing that healthy men with normal weight receiving soft drinks 3 times a day with for 7 weeks with fructose, sucrose, which contains both glucose and fructose, and glucose and controls, had different effects in the amount with regard to the lipogenic effect, and only those receiving fructose and sucrose, which contain both fructose, had really a significant increase in de novo lipogenesis, whereas the glucose group had very minor increase. Let's move a bit to ultra-processed food consumption. This is the most consumed food nowadays. It's about 50% of the calories in our daily diet, and it's a major source of unhealthy types of fat and sugar and other additives. It has been demonstrated in many prospective cohorts to be related with type 2 diabetes, cardiovascular disease, obesity, abdominal obesity, and increased mortality. In a randomized clinical trial, it has been demonstrated that 2 weeks, it is a crossover randomized trial, those eating ultra-processed food as compared to unprocessed food ate more calories and gained weight. So this is food that is designed to lead us to excessive eating of calories. It is very tasty and very tempting. So this is actually demonstrated very nicely in this NIH RCT. We have shown in our 800 volunteers from the general population, we classified their dietary intake by the NOVA classification, which indicates which are the foods were classified as ultra-processed food. And we have shown that those eating above 30% of the calories from ultra-processed food, either the entire sample or the sample specific for ultrasound diagnosed NAFLD patients, had threefold increased chance of having the metabolic syndrome. And interestingly, we found an interaction between smoking and ultra-processed food consumption. So those who smoke and eat a lot of ultra-processed food consumption had a greater chance of having advanced fibrosis, according to FibroTest. Of course, this is the only study I know in NAFLD on ultra-processed food, and we used markers. So definitely it needs to be confirmed in further studies. Just to say that all the bad foods, all the bad guys are actually related in many prospective cohort studies and meta-analysis with increased incidence of HCC. So I think it is extremely important to say to the patients that we do also not only treatment of NAFLD, but also ACC prevention. Very, very shortly on physical activity. Yes, it has an independent effect on the reduction of liver fat, independent of weight loss, as is demonstrated in this meta-analysis comparing randomized clinical trials. And we don't know what physical activity does to NASH or to fibrosis, but this pilot small study of 12 weeks moderate to vigorous intensity physical activity, aerobic physical activity, with very minimal weight reduction, shows some promising results. Those doing their physical activity had a significant reduction in fibrosis stage. So this needs further confirmation, but this is really encouraging. Another recent trial from JHEP reports shows that 3 months exercise has an independent effect on liver fat reduction. They compared physical activity to alone to dietary treatment alone, and there was a weight reduction in the dietary treatment, which led to very nice reduction in liver steatosis and liver stiffness. But with the exercise group, they didn't have actually much of weight reduction, just 1 kilogram. And still, physical activity by itself led to less impressive reduction in liver fat, but still to an independent and an important reduction in liver fat and liver stiffness. Now, this is the only study that I know who looked at a large cohort of people who achieved NAFLD remission and did a 10-year follow-up on these people. And what we can learn from this study that what are the factors leading to recurrence of NAFLD? So we can see that per 1 kilogram increase in weight, not much weight increase, they have a 30% increased risk of having NAFLD recurrence. We can see the difference between those with recurrence and those without. And we can see that you don't need a lot of weight gain or weight regain in order to have NAFLD recurrence. So we need to really keep these patients with a weight reduction. And another thing is physical activity. Those who didn't do physical activity regularly had a greater chance of having NAFLD recurrence. And finally, very few slides. I know time is running out. What do we need to do to help our patients? This is a summary of 51 randomized clinical trials of high quality from the obesity guidelines, showing that we need 3 obligatory factors: behavioral strategies, diet, and regular physical activity. And this is a lifelong treatment. So we need constant contacts with the patients, preferably once a month. And we must encourage them to do physical activity in order to have weight loss maintenance. This is the Look Ahead study. It's not a new study, but it emphasizes the difference between just a general diabetes support and intensive lifestyle intervention, which was much more effective at 4-year follow-up to keep the weight loss for the patients, and two strong predictors for weight loss maintenance was constant contacts with the caregivers and, again, physical activity. We need to create motivation for our patients. They need to really believe that lifestyle modification is helpful. Once we convince them with that, and once we provide them the motivation and self-efficacy to perform a diet, then we would have a much greater success, hopefully, at least. But this is what is demonstrated by several studies. And often I hear that, you know, people do weight reduction diet and they gain most of the weight. So what's the point to have all this trouble for, you know, 2, 3, even 5 kilograms of weight reduction? And so I just want to show you this meta-analysis of people with risk factors for CVD, showing that yes, in long-term follow-up, there is just about 2 kilogram weight loss. Okay, eventually they lose weight, but they gain weight and they stay with minus about 2 kilograms weight loss. But still, this minor weight reduction, as well as with the improvement of dietary composition and maybe physical activity, reduces the risk of cardiovascular disease. So even small weight reduction accompanied with better lifestyle has an important impact in terms of cardiovascular health. The treatment is ongoing. It's a lifelong treatment. Don't remember this. I recommend to see these guidelines by the American Gastroenterology Association. We have the intensive, we have the obesity assessment, we have the intensive intervention, we have the weight maintenance, and then we have the weight gain, regain prevention. It's a circle. It's a lifelong treatment. What happens in reality? This is my last slide. This is a very nice survey conducted in several countries globally, and we can see that although lifestyle advice is provided by physicians to the NAFLD patients, only half of them are referred to dietitian, and only 10% of them are referred to exercise programs. So there is still, we know that diet is important, but there is still a lot to do in practice to help the patients actually to achieve these goals. And with that, I greatly thank you.
Well, thank you, Shira. This was absolutely wonderful. I'm almost out of breath of all this wonderful information. And now, there was also Dr. Alam who thought this is wonderful, and he writes, may I have this wonderful presentation. So these are presentations are being recorded. So I'm sure Lucrezia will let you know how to access these presentations. We have a question from Dr. Leo Robles. Does protein stimulate de novo lipogenesis in the liver? And I guess he's referring to maybe human data on this topic.
Regarding to protein, I'm not familiar with studies looking specifically at lipogenesis. I do know that there are a few examples of high protein diets. One of them compared high protein diet of animal protein, and one compared and it was compared to diet with high plant protein intake. Both of them led to significant reduction in the amount of liver fat. But we need to remember that if you have a high consumption of protein, you have low consumption of carbohydrates, right? And low consumption of sugar. So was it the protein, or was it the fact that it's a low carb diet? We actually can't tell. But with regard specific to lipogenesis, I'm not familiar.
Well, thank you. I think maybe Dr. Peterson can respond to that, and she also has a question for you.
Yeah, I just wanted to come in and you at the end you mentioned the plant-based diets, because I think that's a very interesting concept, both as what we're looking at globally, the health of our planet, but also the health of our bodies. And we have just recently published a paper in collaboration with Hanna Kaleova and Neil Barnard with interventions with plant-based diets. And independent on caloric intake, this leads to significant reductions in both body weight, but also liver and muscle lipid content. So reversing insulin resistance in this relatively simple way. And the hypothesis is, of course, that there probably is less absorption with a plant-based diet, but also there seems to be an indication that it increases energy expenditure. I just wanted to add that in as part of the discussion.
Thank you. I will look more deeply into it. Thanks.
Thank you. I know we are over time, and that's terrible, but that's my fault. And I really want to ask this one more question. This is regarding coffee. I have a friend who thinks coffee contains 400 bad compounds, but the epidemiologist, to me, which I read, suggests that it's actually beneficial. And then I've been trying to look for intervention studies, and I've been quite unsuccessful in identifying. I think I found one study which did not show much of an effect of drinking large amounts of coffee every day. That was from Switzerland. But would you like to comment? What is your opinion about coffee? Is it good or bad?
I would say it's good, and I would say there are 400 good compounds in coffee, mostly polyphenols, different types of polyphenols. So from epidemiological point of view, coffee seems to be protective from general mortality, from type 2 diabetes, and there are also several studies in NAFLD. Some are prospective, but most of them are cross-sectional. So from this perspective, the epidemiological point of view, it seems beneficial. There are many animal studies showing the beneficial mechanisms. So there is a biological explanation to the beneficial effects. In terms of clinical trial, I'm not familiar with, but even if there is a clinical trial with a short-term duration, it doesn't mean that it imitates the long-term effects, right? So you can't compare, I don't know, a week or two of high coffee diet as compared to years of coffee consumption. Actually, we have a study just now accepted in children. I don't know even if it's online yet, but we do have a clinical trial providing coffee to children, believe it or not, and it showed some metabolic benefits, but I will send it to you if it's published already. It was just accepted.
Thank you. We are getting questions just when I thought we have answered all of them. There is one question, maybe I'll just, it's to comment on butter. I guess your answer is that it's not particularly healthy to eat butter. There is Dr. Marchesini from Italy who says, very nice presentation, Shira. Do you believe that psychologists may be part of a NAFLD team?
Absolutely. Yeah. So butter, no. And I mean, in moderation. But in general, the general idea is to reduce saturated fat, and also don't forget the palm oil. Palm oil is found mostly in ultra-processed food, and it is saturated fat, so we should pay attention to palm oil. With regard to psychologists, I completely agree with Professor Marchesini, which has written some fantastic papers on the multidisciplinary approach, which is so important. And obviously we need dietitians and psychologists and physical trainers. But we see that in real life, it doesn't happen much. So we have a lot of way to go.
And then we have Birgitta Strandvik, who says, again, thank you for great presentation. You told saturated to you told differences in saturated to unsaturated fat, but do you have data of polyunsaturated as compared to monounsaturated fatty acids, even N6 to N3?
Yes, this is a really important question because we need to distinguish also between the polyunsaturated types of fat. And we know that, for example, the Mediterranean diet is rich mostly in monounsaturated fat. And the type of polyunsaturated fat in this diet is mostly omega-3 polyunsaturated fat. So yes, there is a lot of complexity here, and we do need to distinguish and learn more about the exact effect of fats. But all I can say right now that most probably monounsaturated fat and polyunsaturated fat from the type of omega-3 fatty acids are the most evidence-based ones to be good for NAFLD. You don't agree, Hannele?
Yes, I do agree. I'm just looking at the time, and
okay.
but I mean, yeah, this is so, your presentation was so stimulating that we're ruining the whole schedule. And Professor Roy Taylor, would you have a quick question?
Very quick. It's really a comment on your question, Hannah. Michael Roden demonstrated an epidemiological study some time ago that coffee was bad. It caused insulin resistance. So he set about doing an intervention study to test this, and it has absolutely no effect. So good news for your question, but it also impinges on a lot of conclusions that are drawn from large cross-sectional epidemiological studies. You just can't rely on association having anything to do with causation. So I think that Shira and I agree on almost everything, apart from, I'd say, the extrapolation from cross-sectional epidemiological studies. So hard data from Michael Roden, red meat has no effect, even though in epidemiological cross-sectional studies, it's an evil thing. So we just need to bear this in mind. Humans are difficult creatures to study, and epidemiology brings that out to the full.
Actually, I agree with you regarding the cross-sectional studies. Of course, you can't conclude causality, this is obvious, but you can have some causality from prospective cohort studies, and there are many of them showing association. And you need to remember that in nutrition, unlike many other things, you can't do randomized clinical trials of 10 years high saturated fat diet, 10 years high meat or processed meat intake, and then see what are the damages. It's just impossible. So you must rely on prospective cohort studies conducted with a very high quality techniques. So I wouldn't say there is no causal inference from prospective epidemiological studies, and we can't always rely on randomized clinical trials, unfortunately, in nutrition.